Hello, everyone. I'm Jason Tokarski.
And I'm Megan McGurman. Welcome to For the Love of Health, brought to you by ChristianaCare.
Cancer touches nearly every family in Delaware, but not every cancer diagnosis is a death sentence.
According to new data released by the Delaware Division of Public Health, cancer mortality rates continue to decline. Between 2008 and 2022, rates decreased by an average of 1.5% per year in both Delaware and the United States.
Here to talk more about what this means for Delawareans and the work being done at ChristianaCare, we're joined by Dr. Thomas Schwaab, the Bank of America Endowed Medical Director of ChristianaCare's Helen F. Graham Cancer Center and Research Institute, and cancer survivor and patient advocate Bill Osborne.
Tom and Bill, thank you so much for being here today.
Thanks for having us.
And I appreciate your interest.
As we mentioned in the introduction to this episode, cancer mortality rates continue to decline in Delaware. Tom, what do you think is driving this progress?
Overall, screening rates are going up. Cancer mortality rates are going down. I think one of the biggest reasons is that we know better how to do cancer screening. At ChristianaCare, we're spending a lot of time and effort to really think about how can you be very thoughtful about your screening efforts. And so we're very deliberate in where we screen, how we educate our patients to screen. You know, it's not only the chemotherapy doctor and the radiation therapy doctor and at some point maybe the surgeon coming in, but it's a very tight orchestration of those three different specialties. And then you bolt onto that all the ancillary services of social work, physical therapy, dietary concerns, speech therapy, clinical trials, and the former patients and or current patients in the OPAC program are true team members in that. So when a cancer patient comes to us for the first time, most of them are seen in our multidisciplinary clinic, and the OPAC team members are a true team member in that group.
Bill, it's aside from the clinical angle over here, you are a member of the Oncology Patient Advocates for Clinical Trials, or OPACT, here at ChristianaCare. Tell us a little bit about your involvement with that group.
OPACT is a group of cancer survivors who have participated in a clinical trial. And we are interested in attracting more interest in other patients once they've been diagnosed, if they're eligible, if it's a good fit for them, to participate in the clinical trial, with the outcome being improvement in the treatment and the outcomes for people with cancer. So this is a group of about a dozen people who've, I say, been there, done that, meaning patient to patient, we can share our journey. We can talk about what is our journey, what have we learned, how did we participate in the clinical trial, how difficult is that, and then encourage others. If it's a fit, it's not a fit for everybody, but if it's a fit, then we ask them to consider joining a clinical trial to benefit everybody down the road.
And how do you feel the clinical trials and just the connection that you make with other patients helps just move the needle on all of this in Delaware, both connection with patients and these better outcomes?
Moving the needle forward, I have my own personal experience. One of the other guys on the group participated years ago in a very similar clinical trial for prostate cancer. He had in excess of 30 radiation treatments, 30. Yes, the technology got better. We got a narrower beam and a higher whatever, but I had 5. I only had 5. And so when we went to a group, we went to the Del Tech and talked to their nursing students about cancer treatment. That's when I learned that I benefited from this guy. You know, we've been sitting in meetings together, but right here is someone who participated in a clinical trial, and I now am the benefactor. And we're all looking to pay that forward to others who are coming. And again, I want to stress, when you participate in a clinical trial, you may not directly benefit. You may be in the control group. But as a whole, we are, to your question, Megan, we are moving the needle. We are getting the overall results to be better.
Clinical trials really are the engine that make us progress as a field in oncology. And I would argue that no other healthcare field has exploded so much in making a change for patient survival. If you think about it, many cancers 10 years ago were a lethal cancer. Lung cancer is the best example. 5 years ago, metastatic lung cancer was a really big problem. And now we can guarantee many years of life on treatment for those patients, but it's meaningful life. Without clinical trials, we would have never gotten there. We at ChristianaCare are recognized on a national level every year for our ability to enroll patients into clinical trials. Nationwide, the average is about 4% of patients get enrolled. We enroll over 30% of our patients in clinical trials. In other words, every third patient that walks through our doors has an opportunity to participate in true cutting-edge, innovative treatment options.
Tom, you mentioned lung cancer, which according to the latest data continues, along with bronchus cancer, to be the leading cause of cancer death in Delaware. What do we have prevention-wise and screening-wise that's helping us make progress on lowering that statistic?
We're actually working hard on that. And believe it or not, we in Delaware are actually doing a much better job than in the rest of the country. So countrywide, screening rates hover around, of all patients that should be screened for lung cancer, hover around 15% or so. In other words, if I do my math right, 85% nationwide should be screened but don't. And there are a number of reasons for it. Access to screening methods is one. Education is another one. Patients ultimately, for whatever reason, don't want to be screened or don't know how to get there. We in Delaware do a much better job. We're around 24% or so, depending on the month, which is good or better than the rest of the nation, but it's still not where we need to be. So we have a lung health program that is staffed by some of our phenomenal nurse practitioners and physician assistants in the thoracic clinic. So if a patient qualifies for lung cancer screening, they can access our lung screening program there. It usually starts with a questionnaire, some health questions, and then a simple what we call low-dose CT scan, which is a pretty straightforward X-ray test. The challenge with lung cancer screening is that many of us will have lumps and bumps in our chest, and that doesn't mean anything. It's not automatically cancer if you have a lump in your chest. However, many of these lumps need follow-up screens or follow-up scans, sometimes 3 months down the road, sometimes a year down the road. Somebody needs to coordinate that. And that's really where we come in with our lung health program. We do a very good job coordinating this, educating the patients. Many times, many of our patients, English is not their first language. And so we need to do that education in their native language.
So lung cancer being the leading cause of cancer deaths in Delaware. As far as the most diagnosed forms of cancer in Delaware, we're looking at breast cancer and colorectal cancer. Tell us about some of the changes that are being made on that front and how we're affecting people there.
So one of our challenges is that different cancers require different screening methods. So for breast cancer, for instance, it's a relatively straightforward screening test with a simple X-ray. Colon cancer is a lot more involved because you require most of the time a procedure under anesthesia or at least sedation, which is a lot more involved, and getting patients there is a bit of a challenge. So it takes a lot of nuanced approaches for us to approach these different kinds of cancers in terms of screening. One of the biggest things that we just started is that in partnership with our primary care partners at ChristianaCare, we have distributed QR codes that are present in every exam room so that a woman that is eligible for breast cancer screening with a mammogram can schedule her mammogram right then and there using that QR code during that doctor's visit. Once a woman then is screened, most of the time it's an annual screening mammogram. Hopefully findings are normal and there's nothing to worry about. However, if there's something abnormal, additional tests need to happen. Again, it doesn't mean that the woman has breast cancer, but the woman may need what we call a diagnostic mammogram and or an MRI scan of the breast with subsequent biopsies. And so we will then have a what we call nurse navigation team in place where we take care of everything right then and there. The worst case for many cancer patients is they don't want to feel left alone. You know, the last thing you want is medical care in general is complex. The last thing you want is to be left alone to schedule this appointment and that appointment, and you don't know how important it is, how urgent it is. And so our nurse navigation team literally takes that kind of blanket of empathy, wraps it around the patient and says, you're not alone. We got your back. We'll take care of you. And we will schedule it. And more importantly, we will provide the information that you may be looking for as well. So one thing that makes us special in the state of Delaware in a bad way is that we have a higher rate of African American women that get diagnosed at a younger age with a more aggressive breast cancer than other women in the country. And we don't really understand yet why. However, a lot of our basic science research is focused in that area. Our current screening guidelines recommend for women to start screening at a certain age, but if you end up being diagnosed at a much younger age with an aggressive breast cancer, that doesn't help you. So how can we identify women that are at risk to develop aggressive breast cancer at a younger age? And so we have done a lot of work under Dr. Siegel's leadership to identify not only zip codes, but neighborhoods and literally street blocks where women live that are at higher risk. And so one of our efforts is to hire community health workers that literally go into these neighborhoods and identify women that should be screened, not saying that they do have cancer, but they should be screened, and provide all the education and then the navigation around that screening piece. And we're able to do that in the state of Delaware because we have Dr. Siegel's research happening right in our cancer program. ChristianaCare in the state of Delaware actually has a history in reducing mortality rates in colon cancer. So a couple of decades ago, we were, as a state, we were able to show that a concerted screening effort around colon cancer screening can reduce mortality rates in colon cancer, and that has been published, and frankly, it hasn't really been able to be replicated by any other state in the nation. So we do play a pivotal role in the history of cancer screening in general.
The latest data shows that Delaware currently ranks 15th nationally for cancer mortality, which doesn't sound great. But considering 30 years ago we ranked second, this is a huge step in the right direction. What should other states be looking to Delaware for that we're doing that they might be able to institute?
I think in my mind, it's the boots on the ground work that we are doing with our screening navigation teams, with the work that I mentioned about Dr. Siegel's work. We are fortunate that we are a relatively small state, and we can really focus our resources in those areas and literally focus on certain neighborhoods to do the necessary education and screening navigation. How often do I see a patient that walks into the cancer center and they look scared? They are standing in front of the board with the different practice locations and doctors' names, and they just look, lost. Yes. And my heart goes out to them. So we at the Helen F. Graham go out of our way to take those patients literally by the hand and walk them to where they need to go, and then there will be a warm handoff. So I would encourage everybody who has that unfortunate situation, come into our cancer center and try it, because you will find that is pervasive throughout. We, in partnership with our friends, other patients, will take care of you.
It is so true. People come walking in that other entrance, and we're sitting there, we say, can we help you with something? And this guy's wearing a Dallas Cowboys hat. Now, why are we going to start a conversation with him? I mean, but we got something to talk about. It's, oh, no, I'm here to see. And then the other people start coming in and saying, oh, I can get you up there. I'm going up on the elevator. So it is very important because it is overwhelming. You can't say it's challenging. It's not. It's worse than that. And to have someone there to say, come on, let's go, is a big step.
It's a little bit inevitable that everyone will be touched by cancer in some way, whether it be a personal battle or a loved one's battle. What is your message to those who are listening to this thinking, how can I be a part of this? How can I help move that needle and continue to lower rates, whether you're in the center being treated or not?
Let me give an uninformed, and then you can follow up with an informed opinion. The uninformed opinion is get tested. I can't think of any situation where delaying is going to be to your benefit, okay? And knowledge is powerful. So let's figure out, truthfully, what's going on. So to me, if you want to move the needle, then you have to start with testing, screening, and get useful information. Now, the informed decision.
To me, it's about the dialogue and the conversations. Have the conversation at the dinner table. Hey, listen, did you get your PSA test done, Dad, grandfather? Mom, did you get your screening mammogram done? Or you didn't, why not? Let's talk about it. I think we as a community resource are more than happy to be available. If there are questions, participate in our 5K run, and at the last Sunday in September, there'll be all the information you are looking for, right? Just make it part of the conversation. Our cancer program is part of the community, and we should be part of the conversation every day.
Tom and Bill, thank you so much for this conversation today.
Thank you for having us.
Enjoyed it.
Check out the show notes for more information on the ChristianaCare Helen F. Graham Cancer Center and Research Institute.
And be sure to subscribe to For the Love of Health on your favorite podcast platform or on ChristianaCare's YouTube channel.
We'll be back in 2 weeks with another great conversation.
Until then, thanks for joining us
For the love of health.